Say hi to everyone who's watching us live. Welcome to another Facebook Live session. My name is Zoe Clark. I'm Self-Management Programme Officer here at NASS, and today I'm delighted to be joined by Dr. Danny Murphy, who is a GP and staff grade rheumatologist. Hi Danny, how are you?
Hello, yeah, good to see you. Nice to be here.
Yeah, thanks for joining us. I think this will be a really popular session. So for everyone watching, Danny is going to be chatting a little bit about when you should see your GP versus when you should see your rheumatologist, and how to get the most out of your GP appointment as well. And we'll also be able to answer questions at the end, so please do pop any questions for Danny in the comments. Obviously, he can't answer anything too clinical and specific to you, but if there's anything sort of GP related, he'll be happy to answer those. So I'll just check. Just make sure that my tech is catching up. And if you are watching, just pop a comment in there just to say hi, let us know where you are, and yeah, any questions. And if you can't watch the whole session, then don't worry, you can catch up on our Facebook page afterwards. The video will stay here, and we'll also upload it onto My AS, My Life on our website and our YouTube page as well, so you can come back and catch up later on. Wonderful. So was there anything you wanted to add before I hand over to you, Danny?
No, not from me.
Okay, brilliant. Yeah, we've got quite a few people watching already. So what I'll do is I'll hand over to you to have a general chat, and then I'll come back to the Q&A.
Brilliant, thank you. So I think what I've been asked to talk about today, so as Zoe mentioned, a couple of things. So thinking about people often can find it hard to work out where the line lies really between who should be managing what within the healthcare, what should be managed by the rheumatologist, what should be managed by the GP. And then we talk briefly about how to get the most out of an appointment with your GP. So my role, I normally say I'm in sunny Exeter, but it's definitely not sunny. It's definitely cold and grey and damp outside. But I live and work just outside Exeter in Devon. So I spend half my week as a GP in Honiton, so the market town in Devon, and half my week working as a hospital rheumatologist in Exeter. And I'm also a medical advisor for NASS. So thinking specifically about that dividing line between primary care and rheumatology, and it's often a bit blurred. Can often be difficult to work out. But if you think about what rheumatologists do, they're specialists in managing rheumatology conditions, so inflammatory conditions. They're really good at that. They're not necessarily generalists. So rheumatologists are very good at answering special questions about specific medicines. So specifically drugs like biologics, which a lot of people with axial spondyloarthritis will be taking. Specific questions that relate to the disease itself. But they're probably not as good at helping you with topics outside of that. So for example, thinking about HRT or contraception, managing high blood pressure, thinking about psychological health and mental health. So rheumatologists might not be as good at that. So when we think about what we provide in primary care, we often talk about this phrase of holistic care. So what that means, holistic literally means it's in a circle. So thinking about that circle, thinking about layers of an onion, right at the core of it, if you've got spondyloarthritis, those specific things relating to your spondyloarthritis and specific medications that are prescribed for that disease, for your ankylosing spondylitis, they're the things that your rheumatologist will be able to help with. And usually that's often via a helpline. It's the stuff on the outside of that circle, so the outer layer of the onion, that your GP might be better at helping with. And we know that having a disease of inflammatory arthritis or spondyloarthritis can affect lots of bits of your life, so particularly your mental health, so your psychological health. So GPs are often well placed to help with that, or at least signpost onto services that can help manage some of those symptoms. GPs are often good at helping with pain. So some of the treatments that you might take specifically for your spondyloarthritis are there to stop the disease, and they'll also help reduce pain. I think specifically about painkillers and questions about painkillers, I think GPs are very good and very well used to offering advice about that. And then also thinking about all the things that run alongside spondyloarthritis that we know you might be at increased risk of. So thinking about the health of what I would call cardiovascular health, so your heart and blood vessels. So we know that people with inflammatory disease sometimes can have an increased risk of disease of the heart and blood vessels. So GPs are very good at helping prevent that. Now that might be healthy living advice. Thinking about lifestyle advice, but exercise, weight loss and a healthy diet, or it might be medication. It might be prescribing drugs to lower your cholesterol or lower your blood pressure. And all of the things that run alongside that. So thinking about keeping your heart and lungs healthy, thinking about keeping your kidneys healthy. GPs are very good at that. So if, thinking about, who should I call? I think in general, if your question is about specific medication related to spondyloarthritis or a specific query about managing your spondyloarthritis or ankylosing spondylitis itself, then that might be best directed towards your rheumatology team. Anything else, sort of on the outside of that circle, as we talked about, might be best managed by your GP because they've got a better idea about your overall health. And I think that then moves on to thinking about getting the best out of an appointment in general practice. And often that can be difficult because I think, from my end of the spectrum, sitting as I do in my consulting room, seeing 40 to 60 patients a day, often it feels a bit like a conveyor belt. I'm sat there in my room and I'm going from patient to patient to patient to patient, and it moves very quickly. I think what I often try to do is to sit back and think about the patient that's sat in the waiting room, because for you, it's not a conveyor belt. It's your 10 minutes. You've been waiting for this opportunity for a long time. And for me, what I need to do is to try and maximize that 10 minutes for you, to try and make you feel and to try and show you that I'm concentrating on the problems that you come to me with, and they're very important to me. But also to realize that actually you have been waiting for a little while. Often you've been waiting for a while for the appointment, and there might have been a delay in the waiting room. And how can I help maximize that time for you? So I think what I would say to patients is to remember that it is a 10-minute appointment. And we would all love to offer patients more time, but sadly we can't. So trying to maximize that time and make our use of that time as efficient as possible is really important. So I think the first thing I'd say is remember that often we can't deal with multiple appointments in the same, multiple problems in the same appointment. That if you come to an appointment with the expectation that we might be able to manage 4, 5 or 6 things, we're probably not going to be able to do that. So thinking before you get to that appointment, if you have multiple things, what are the most important 2 or 3 things here that I want to get out of this appointment today? Often that's what I'll say to people if they come to me with a list of several things to say, look, I'm really sorry, I can't deal with all those today, but of those, which are the most important? Which can we chalk off the list first? So having an idea of that in your mind before you get into that appointment is helpful. And I think lists are really helpful as well. They're helpful for you, they're helpful for me. They're helpful for you because when you get into an appointment, what we know is that of the stuff that I tell people during an appointment, the way the human mind works, we only remember about 10% of it. And once you start getting into your flow of explaining the problems that you have, sometimes it's easy to forget things. So having a list there to remind you is really helpful. But it's also really helpful for me, if you can show me a list at the start of an appointment, I can look down and we can say, well, look, for you, these are the important things. This is what we might want to deal with. But I might look down the list and say, well, actually, do you know what? Looking at that list, I'm a little bit worried about this here down the bottom. So even though that might be of less importance to you, actually using my experience, I might be a little bit more concerned about that. So I think lists are really helpful. So people often worry that if they come in with a list, they'll be thinking, oh, people have been quite demanding and they've come with a huge list of things. But actually, I think it's really helpful. And I think writing things down during an appointment is often really helpful as well, just as a little memory aid, so that you can say, well, this is what we discussed, and it can just jog your memory about the contents of an appointment. And what are the important things to think about during a review appointment? Well, it's the things that we've talked about. If I think about seeing somebody in general practice with spondyloarthritis, I'm not necessarily thinking about managing the spondyloarthritis in itself, because I'm going to leave that to the hospital rheumatology team. What I'm thinking about are the things that we're really good at in general practice, and that's thinking about you as a whole. So thinking about promoting a healthy lifestyle. What can I do in that 10 minutes to help you live the healthiest lifestyle possible? Promoting exercise, healthy eating, keeping a healthy weight, cigarette smoking and alcohol are often the things that we talk about. And then also, as we said, sort of joining the dots and seeing you as a whole person rather than one specific disease. So thinking specifically about your psychological health. You know, can I ask some questions that might help you explain how you're feeling if you're not feeling as healthy or as well as you want to? Getting that information out quickly, helping me work out what I think the problems might be, and then also signposting you on to a service that might be able to help you best. And then also thinking about your physical health, the things that we talked about. So for younger people, that's often particularly young women, it's contraception, thinking about some of the drugs that we prescribe, which can sometimes have problems with conception. And then psychological health. And then as we get older, thinking about some of the, what I would call comorbidities, so some of the problems that can accumulate as a consequence of having spondyloarthritis. So thinking about your blood pressure, your cholesterol, and your risk of heart attack and stroke, which is something that we want to reduce as to the lowest possible it can be. And then also thinking about some of the other organs that can become affected either by disease or by treatments. So thinking about your kidney function, maybe thinking about blood tests, whether we need to request those. And then also screening for lots of the diseases that we screen for as we get older. So thinking about kidney function, diabetes in particular, is something that we screen often for. So just to sort of bundle that up, we talked a little bit about, trying to differentiate between a rheumatology spondyloarthritis specific problem, which might be best served by your rheumatologist, or a more sort of holistic general medicine problem that might be best served by your GP. And then thinking about how to get the best out of that appointment. So thinking, what are the 1, 2, or 3 most important things to me I really want to get out of this appointment? Maybe thinking about writing a list and writing things down. And then thinking about some of the things that your GP might be best served to help with, particularly sort of contraception, psychological health, looking after your heart, lungs, and kidneys, and living a healthy lifestyle. So that's it from me. It's slightly terrifying when I can't see anybody else. I can't see anybody's faces. I hope that's sort of what everybody was hoping for. Zoe, over to you.
Absolutely. Thank you, Danny. I know it is strange talking to what seems like an empty Zoom room, but no, that was perfect. That was really good information for everyone. We've had quite a few comments and questions coming in as well, so hi to everyone who's watching live. We have had a few specific clinical questions, so my colleague Sally and I have just been giving people advice in terms of who to speak to, because obviously you can't give specific clinical advice like that for people. Perhaps to start us off, we have had a couple of questions from people wondering about how the GPs can get some more sort of AS and Axial SpA specific knowledge. Is there anything GPs can do to kind of increase their learning around this area, because obviously it's such a specialist topic?
Yeah. So there's this really good bloke called Murphy who's written a few things recently. So declaring interest, I did write them. But I think there are some specific resources. The Royal College of GPs has a module on their website specifically about axial spondyloarthritis to provide an information for primary care. So GPs can have a look at that. So NASS supported and funded that, which we're really grateful for, and it's a really good resource. So I think that shows some of the fantastic work that NASS do in raising the profile of AxSpA and helping GPs progress and evolve their knowledge. I think the other thing that I'd encourage GPs to have a look at on the Red Whale website, which is an organisation that provides GP education. We've done a number of modules recently in association with Versus Arthritis, looking at managing diseases like axial spondyloarthritis and rheumatoid arthritis during the COVID pandemic. So I think they're really useful. And I also think that Versus Arthritis run a really good course called Core Skills in Musculoskeletal Care, which GPs can access. And again, so I'd signpost people towards those because I think they're really good resources and a source of updated information.
Yeah, that's fantastic. It's great to know that there's lots out there, and yeah, and thank you for contributing to all of those as well. And as you said at the beginning, being on our medical advisory board as well really helps us get kind of the right information out there to the right people. So in terms of a next question, in fact the previous talk you've done for NASS, where you described kind of all the things you've got going on your screen and on your computer during an appointment that you have to do while patients are with you. Sally and I thought, if you're happy to just share with us kind of what the appointments involve for you and what you have to do kind of on the computer during each appointment.
Yeah, sure, we could think about that. So without getting too deep into the mechanics of it, so as when I work in the hospital, I'm an NHS employee, I get paid a salary, and I get paid that every month when I come to work. So general practice doesn't work like that, and I think people sometimes don't appreciate that as GPs, we run a small business. So I don't get a salary. We run a business, and the NHS contracts us to provide primary care services. And as such, I get paid in two ways. So we get what's called a global sum. So you get paid pounds per patient on your books. That's adjusted up and down if you have lots of patients who are frail, elderly, complex, etc., etc. So that's one way that we get paid. Second way that we get paid is this thing called QOF, which you might have read about if you read some of the sort of health articles in the paper. So QOF stands for Quality and Outcomes Framework, and that's was designed as a way of essentially paying GPs for results. So what we have to do for QOF, there are a number of different things that we have to do in order to get paid. Now, for people who are young, fit, well and healthy, that's not an awful lot of work. But as people get a bit older and accumulate some diagnoses, the amount of work we have to do in order to get paid for looking after people grows and grows and grows. So if you've got high blood pressure, we have to measure your blood pressure every year. There's certain things we have to do. If you have diabetes, there's actually quite a lot we have to do. Now, there are good reasons for that. This isn't there to make GPs cross, although it feels like it sometimes. The aim was to try and improve care and improve outcomes. I think the difficulty for us as GPs is that sometimes it definitely gets in the way. I'm an employer. I employ lots of staff. I've got to pay to keep the lights on. So as much as I hate doing it sometimes, I've got to tick these boxes to get the money in to run the surgery. But often I can look at the sidebar of my little piece of software and there'll be 10, 15 alerts popping up saying, look, this needs to be done, this needs to be done, this needs to be done, this needs to be done. So I think that might explain sometimes why, as GPs, we might seem maybe a little bit distracted, or it might seem like we're asking you questions that aren't relevant to the reason why you're coming in. But they're there for a reason. They're there to look after you and to improve your health. I think that's the first thing that's important to say, but it's also, doing these things are what enables us to keep providing services and literally to pay the bills. So I think, it's a really, really interesting question, about sort of what is going through my mind as a patient walks in through the door. So I've alluded to it when I was talking. I think what we have to try and do is to try and step away from that sometimes and remember that the patient that walks in has travelled to the surgery, has sat in the waiting room for 20 minutes, half an hour, might have waited 2 or 3 weeks for the appointment. For them, this is sort of an event that starts the minute they walk through the door. For me, my event that day might have started 3 or 4 hours earlier. I might not have eaten lunch. I might not have had time to have a wee. I might be tired and grumpy. The last person I've seen might have shouted at me. So trying to draw a line under that and trying to say, right, okay, it might be the 50th patient of the day, you might be the first, but trying to treat that patient as an individual with all the other stuff that comes through is really hard and something that I'm still trying to get better at.
That's really interesting, and thank you for sharing your experiences as well, because I think it's easy as patients to not understand that either. So I think kind of sharing both ways is really helpful in kind of establishing that kind of good working relationship, really. And yeah, at least today you had time for your Kit Kat break before the session.
Yeah.
Just looking back at the questions, we've got a few more that are coming in. We've got a comment from Kathy. She said, firstly, she said, hi, this is really helpful. So I'm glad. She said, I often get asked if I have a care plan. Does the GP have this? I'm imagining that's referring to like an Axial SpA care plan overall.
Yeah. So your GP wouldn't necessarily have access to that. I think a care plan is a good idea. I think, what I often ask people to think about is a sort of good day and a bad day plan, or a sort of red, amber and green plan, like a traffic light. So when I think about a care plan, that's how I might ask people to think. So on a green day, on a great day, what are you going to do? Hopefully that'll be most of your days. On an amber day, when you're not feeling quite so well, what's your plan? What are you going to do? And on a red day, when either you're feeling awful or there are some symptoms there that we might worry about, what are you going to do and who are you going to contact? But your GP might well not have had that shared with them. I think, if we, again, without getting too much into medical politics, if you look at the NHS 5-year plan and moving forwards, care planning is a big part of that. So helping and encouraging patients to contribute to their own care plan is going to become a more and more important part of general practice. Now, that might not necessarily be targeted at people with axial spondyloarthritis, and that's much more targeted at the people who, being honest, consume the mental health resource, and that tends to be frail elderly patients with lots and lots of diseases. So that's where care planning is primarily aimed. But I think, for anybody with a chronic disease, I think a care plan can be really helpful. And it can be really helpful for those reasons that we talked about. It's not necessarily putting hard and fast rules in place, but saying, look, okay, on a good day, what are you going to do? But also have a plan in place so that if you wake up in the morning, you're having a bit of a flare, you're feeling stiff, how are you going to manage that? Okay. What does good look like for you? What do you want to do? What are your aims and objectives for your good days? Because they might be different for different people. If you're 24 and really active, it might be being able to play football for your football team. If you're 84 and really struggling, your good day plan might be able to say, well, I want to take my dog for a walk. So understanding that is really important. But then thinking, okay, on the days when you can't do that, how are you going to manage your symptoms? What's your plan? What are you going to reach for? What are you going to try and do? And if that doesn't work, what are you going to do next? Who are you going to ask for help? And on those really bad days when you're really struggling, or when you've got those symptoms that, as a doctor, I might worry about, who are you going to call? What numbers are you going to reach for? How are you going to ask for help? And just having that planned in advance is really important. And I think we can learn a lot from people with asthma, because if you think about managing asthma, for a long time this has been done, and we're really good at getting care plans in place. And if you look at Asthma UK, they've got a lovely leaflet that's split into a green and amber and a red column, and it's really, really simple and straightforward. And most asthma patients will have seen that at some point. To move into that model, I think, is going to be really helpful in the future. And I think the NHS will hopefully get better at that. I was going to try and avoid the C word, but it has got in the way of quite a lot of these things that we wanted to do. But hopefully, as the great unpleasantness eases and we get back to a more normal way of working, hopefully that should become something that becomes more routine.
Absolutely, yeah, certainly not a kind of usual time at the moment, is it? Yeah, we'll avoid that word if we can. That's really helpful to know, and good to kind of describe what patients can do to kind of help put that plan together as well. There's a lot of crossover with, we did Facebook Live about managing flares. We talked about having like a flare book where you have the list of all the things that help and contact numbers and things like that, and similarly working with your physiotherapist on on what exercises are you going to do on a good day, what are you going to do on an okay day, and on those really bad days, what's best to help. So yeah, I think all of those together sound really good. Just having a look at the comments again. This could probably be like a 1-hour lecture, I think, this one. She's asking about, because NASS are trying to bring the diagnosis time down, and it took him sort of 15, 16 years to get a diagnosis. So he said, how can GPs recognise the symptoms without referring everyone with backache to rheumatology?
I think you're right. I think that is probably a whole day's course. I think, again, what I'm going to do is I'm going to sort of put my hand up for all the GPs in the UK and sort of advocate for them and say that nobody wants to do a bad job. You know, we're all trying our best and we're all swimming against, you know, an enormous tide. Back pain's a really common presenting symptom to general practice. It's one of the commonest reasons for coming into general practice. So we see a lot of back pain. And I think, again, trying to sit in my chair, axial spondyloarthritis, an inflammatory disease, is a relatively uncommon cause of a very common problem. So in the huge numbers of back pain patients that we will see, it's very infrequent. So it is that sort of needle in a haystack, to use an inappropriate phrase. Doesn't mean it's not important, but it does mean that for your average GP, they're probably only going to see one new presentation of AxSpA every couple of years, 5 to 10 years. So it's really rare. So it's really difficult. I think for me, how are we going to do this? Well, we talked about sort of the educational modules that are out there. I know NASS have got some really big, exciting plans about how they're going to try and do this and how they're going to try and raise the profile of AxSpA. I think I often teach GPs and just say, look, just keep it simple. There are some really simple questions that you can ask that should just raise your suspicions of AxSpA. And that's particularly symptoms like back pain that comes on without an obvious injury or twisted injury, back pain that worsens with rest and eases with exercise, and back pain that wakes you up at night. I think if we overcomplicate things, that can make things very difficult, but they're the things that I ask GPs to concentrate on. So yeah, I think you're absolutely right. I think that is a very long, very difficult, very detailed question to answer. And the honest answer is I don't think anybody really knows the answer. But I think NASS is doing amazing work in keeping banging the drum and keeping raising the profile of AxSpA amongst the general public and amongst GPs. So the more we do that, you would hope that the quicker we can reduce that time, that delay to diagnosis.
Absolutely, and I totally agree. I think, across the board with all healthcare professionals, I think it is just that raising, both the knowledge and the level of sort of awareness that we're sort of paying to it, really, to spot those cases when they come along. I know I don't know how much I can say, but yeah, the NASS plans are exciting, and that it's going to be looking at things across the board and the public as well, so that we sort of raise the awareness and the knowledge generally. Brilliant. So just having a look at questions again. We've had a slightly more specific question in from Vanessa, who's asking about if her GP can prescribe a 2-week course of prednisolone to take on a 2-week walking holiday in Spain, just in case she has a flare-up while she's away. I'm not sure if that's something you can answer, but so feel free to say if it's something.
I think without knowing sort of specific details about our case, that's difficult. I think, what would I suggest in that case? I think probably liaising with your rheumatologist first would be reasonable. I think listening to that.
Yeah, so sort of through the helpline if they've not got an appointment coming up. That's brilliant, thank you. And I apologise if I pronounced your name incorrectly. Jian has asked, any new developments in treatments on the horizon?
So I think there always are, and I think it's one of the exciting things about working in this field is that if we look back to 10 years ago, things have moved along hugely. So yeah, absolutely. I think there are definitely new drugs in the pipeline, but I think one of the really interesting things about looking after patients with AxSpA is that there's been no drug has ever been shown to be better than exercise, and I think that's one of the really interesting things. And particularly thinking about we were talking about lifestyle and lifestyle management and how your GP can help with that. Stretching regularly, exercising regularly, keeping a healthy weight, avoiding cigarette smoke are all hugely important. So yeah, absolutely, there are definitely new drugs, and there are new drugs in the pipeline, which I think will be really helpful. But I think that's one of the nice things about working in this specialty is it's still really important to think about the really simple things.
Absolutely, yeah. And we have a question from Richard, who's just about to start biologics for the first time. He said if he has any issues or problems, would it be best to only ask rheumatology, or would a GP be able to help with sort of any biologics questions?
So I think biologics are quite specialist medicines to prescribe. So I think asking specific questions about biologics are best probably directed to rheumatology. There are things that your GP might be able to help with, and it's things like, if you go on to a biology, you'd be told quite a lot about infection and the risk of infection. So, any problems with infection, I'd probably go to your GP first, but specific, questions about medications themselves or side effects are probably best directed to your rheumatologist.
Okay, that's brilliant, thank you. I'm just going to check on my phone as well, make sure that we've not missed any questions, because I think we have covered everything. Had quite a few coming in, so it's been obviously really helpful for people, and lots of people watching live as well. Yeah, I think we've covered everything there. So I'll give everyone just a few seconds to pop any burning questions in before we finish up. Do you have anything else you wanted to add, Danny? I know it's been loads of info already.
No, not from me. Thank you for having me.
Yeah, no, thanks so much. It's been really, really helpful. Yeah, answered loads of questions, and it's also been really popular, so thank you. I'll just let everyone know for our next session, we don't have a session next week. Our next one will be the week after. So on Wednesday, 26th of May at 1 p.m, we will have Ian Young, who is a somatics movement teacher, and he'll be back doing another somatic session, this time focusing on the neck and shoulders. So if you haven't seen his previous session, head back to our previous Facebook videos and you'll see that one there. You can give it a go before trying this session. As always, with all the exercise sessions, check with your doctor if if you're unsure if it's going to be suitable for you beforehand. Yeah, so I think that has covered everything. Oh, one last question, just in the nick of time. Shabana has asked, so thanks for all the info. She said she has problems with her eyes, diagnosed at eye hospital. For any sort of problems, who should she ask for advice for that? That's quite
So again, I think that's difficult without knowing the specifics of your eye condition. But I think in general, questions related to a specific eye diagnosis are probably best directed to your ophthalmologist. Whereas your GP might be able to help with, questions that are much more about general health.
Brilliant, thank you. She asked that just in the nick of time. So thanks again. It's been a really fantastic session, and really appreciate your time today. Hopefully the rest of your day isn't too busy, hopefully.
Good, no problem. Take care.
Take care. Bye.